Good day, all, and welcome to the Teledyne Pulse podcast, your Rural Health Matters resource. Hear from your colleagues and industry experts on rural health issues and innovative care models that make a difference for rural hospitals, providers, and communities.
Welcome to the next edition of the Teledyne Pulse podcast. I'm Andy Whitney, Director of Marketing for Teledyne Health. Shane, who do we have with us today?
Well, thanks, Andy. Shane Fleming, co-founder, CDO of Teledyne Health, and excited to be on the Teledyne podcast today. We have some fantastic participants today that are really going to make this show just top notch. So I'm very excited to introduce Shanna Stofer and Dave Burd from Jennie Ed Hospital in Council Bluffs, Iowa. So I'm very excited and honored that they're willing to take time out of their day and chat with us, Andy. They got an unbelievable message to share, and excited to introduce them. So, Shanna, you want to introduce yourself?
Yeah, thanks, Shane. My name is Shanna Stofer, and I'm Vice President of Ancillary and Professional Services here at Jennie Edmundson. And thank you for having us today.
Oh, absolutely. Dave?
You bet. Dave Burd, President and CEO here at Methodist Jennie Edmundson Hospital in Council Bluffs.
Well, that's excellent. And again, I can't thank you enough for spending some time with us today. I know your schedules are beyond busy, and to take some time to share your thoughts on our podcast it's humbling. I'm shocked and honored that you guys are willing to participate with us today.
Glad you could join us.
And that brings us to kind of why we're here today, and that is to talk about success in replacing a neuro and stroke program with telestroke services and teleneurology services in a large urban hospital. And the story here at Jennie Ed is a good one. And it's very interesting how we came together on this particular project and ultimately what's gone on since the project's inception. And we're going to talk today a little bit about the journey that Jennie Ed took as part of this process, and Dave and his team took as part of this process. And I know, Dave, when you and I got together here, oh gosh, it's been quite some time ago when we initially had the conversations about what your pressing needs were at the time. But it was really, it was a scenario and a situation that we hear pretty frequently, really, in a lot of the facilities, both large and small. And I think people are going to be very interested in what you have to say today. And so I think we can get started with just some of the questions. And I think initially, on a journey like this, an area that we always like to start with is really, as you look at your journey, what really prompted your organization to take a look into a virtual stroke and a virtual neurology option for a facility based on your location and size. And on that note, I wonder, Dave, if you could potentially just give some background about Jennie Edmundson over there in Council Bluffs, Iowa, and then we'll roll right into the conversation.
You bet. We'd be glad to do that, Shane. And first of all, we're really looking forward to the discussion today as well. And I know Shanna and I both appreciate the opportunity to be on the podcast today and to share a little bit about our story and our journey forward using teleneurology through Teledyne. Really believe we have a strong partnership and are doing some great things together. So first of all, Methodist Jennie Edmundson Hospital is located in Council Bluffs, Iowa. Council Bluffs is a community, for those of you that are not familiar, of about 60,000 people. Council Bluffs is also part of what is referred to as the Omaha, Nebraska metro area as well. So while Council Bluffs itself isn't necessarily a really large community, it is also part of the metro area, which in terms of population is around 1 million people and is continuing to grow. So we're located in Council Bluffs, and as part of being part of the metro, there are multiple systems that are in the healthcare space that compete, obviously, for patients for our services and for staff to work at our facility. So we are in a very competitive environment. Jennie Edmundson Hospital is part of the Methodist health system. Methodist is comprised of Methodist Hospital and Women's Hospital in Omaha, Fremont Health and Fremont, and then of course us in Council Bluffs. Jennie Edmundson is proud to offer a wide variety of services that are very comprehensive. We are a growing organization. We have a lot of service lines that are growing in terms of volumes, and we're doing some great things. excited and proud to say that from a facilities perspective, we have invested significantly in recent years, have completed some very large projects and have other significant projects coming up in the next few years as well. So a lot of exciting and great things going on here. Would also like to just emphasize briefly that we really prioritize partnering with all of the rural critical access hospitals around us as well, in terms of outreach, in terms of education, in terms of treating patients that they may have that may need a higher level of care. We really work hard to make sure we're strong partners with those facilities around us as well, and believe that's part of our responsibility as a regional organization. So a lot of great things going on, a lot of things that we're, as you can tell, that we're proud of. So in terms of our journey and what kind of led to us looking at maybe a virtual neurology option, historically, we were lucky that we had some on-site neurology coverage, primarily during the weekdays, and then used a different telehealth service to fill the gaps, so to speak, on nights and weekends primarily. And this arrangement was in place for several years. It worked well for us, and we were glad to have that. Unfortunately, in early 2022, the neurologist that had provided on-site coverage to us historically during the weekdays notified us that he had made the decision to kind of pull away from hospital coverage and to focus primarily on his clinic. And so at that point, we were able to get him to continue providing coverage for a little while longer after that, but then found ourselves simply utilizing the telehealth provider that we had in place before that. And quite frankly, in their defense, when we first entered into that agreement, it really was simply for nights and weekends and to kind of fill the gap, as I stated, not necessarily intended to be a full service comprehensive neurology program. And so once our neurologist kind of pulled away, we were kind of left with trying to identify what kind of solution we wanted to pursue moving forward longer term. And we found ourselves leaning on the former telehealth provider. And quite frankly, we were starting to hear lots of concerns from both providers and from staff related to the service that we were receiving from that previous vendor. In terms of lack of responsiveness, we had some technical issues with some of the equipment that led to some delays in care, delays in responses. And so the level of concern, the level of frustration from both providers and staff just seemed to continue to increase. And so obviously we recognized that we needed to do something. We needed to find a longer term solution and started to look at various options, including, whether we could find on-site coverage, and if not, exploring other telehealth options, including Teledyne. So Andy and Shane, that's just a little bit of our initial part of the journey and kind of what led us to working with you.
Yeah, appreciate that overview, Dave. Again, you guys are doing some amazing things over there in Council Bluffs. One of the questions I have, based on what you just said there, but when you got into the recruitment part of it, you mentioned, which is kind of at first blush is a typical reaction where people like, let's go recruit. Let's bring more neurologists into the mothership or into the metro area to provide these services. Can you maybe shed some light on how that recruit process went? I mean, did you have applicants, or was it a struggle to find people that were halfway interested, or did you feel like you're kind of spinning your wheels? What were you seeing on that front?
Yeah, initially I think we focused more so on local coverage, local neurologists. We did not formally recruit a neurologist. We did have conversations within the Methodist health system. We did look at maybe some other local providers that perhaps could provide coverage. But as you know, generally speaking, there was a lack of neurologists available. Those that practice in this area were extremely busy, and their capacity was very low in terms of considering taking on additional coverage. And so we did look at that initially, did not formally recruit it, but did recognize pretty early on in the process that we probably needed to start looking at some other options.
Sure. And I appreciate that. We hear frequently that the recruit, really regardless of the specialty anymore, is a very difficult recruit, and even in the urban and metro areas, even in whether it's the Lincoln or Omaha market, at least in terms of Nebraska, it's been a challenge. But in the other 10 states that we're in, we're seeing similar challenges too in terms of recruitment.
Especially in the rural markets.
Right. But you mentioned, sort of a hybrid model initially, where you had some boots on the ground coverage and you leveraged some occasional or periodic telehealth coverage. And as you pondered the decision, kind of going through this journey on investigating additional programs, and as you mentioned, a little bit more of a comprehensive model, which includes not only neuro coverage of all neuro issues, but then stroke coverage as well. And then from the ED, and then being able to round and see patients on the inpatient side as being more comprehensive as well as overall supportive. But as you talk with the medical staff, and as you mentioned some concerns coming from some of the providers, I know there were some concerns from some of the nursing staff. What were you hearing in terms of, or did you get the sense that was really going to be a fundamental change necessary as part of the normal practice that your providers were typical or used to seeing over the years? And oftentimes when we deploy these types of programs, in some cases, it's a dramatic fundamental shift from where they're at, where their traditional practice has been, and in terms of what does this look like moving forward. But did you see or notice, or what were you hearing from the medical staff as you pondered this type of option or decision?
Yeah, as we continue to look at a potential comprehensive teleneurology program, we recognize some changes would probably be necessary, but in terms of a dramatic change, I would say not really, simply because we were already using a telehealth service in the past. Providers and staff were at least somewhat familiar and comfortable with that kind of concept of using an offsite telehealth provider as compared with an on-site provider. And so I think that was an advantage to us, since we had at least a piece of that implemented historically. And I think that made the transition a little bit easier for us. A little bit easier, that because from the perspective of some medical staff and staff overall, things were pretty bad from their perspective already. And I think there were some that were looking at this in terms of considering another option, that, well, could it really get any worse? And so I think where we were at the time, our specific situation and circumstances helped increase the willingness and the receptiveness of our staff and providers to considering another option.
Sure. Well, I appreciate that. I'm curious on that note. You mentioned some the concerns or the dire situation that you had. Were there concerns if, in other words, did you hear, well, gosh, if you want to replace this with another or different virtual program, is it going to be the same, or is it going to be different than what we're currently using or seeing? Sometimes we run into that too, where they say, "Oh, so this virtual program's not working," and let me get this straight.
You want to do another virtual
program, and you really tell me this is going to work?
Yeah.
But that's we get those types of responses quite a bit when we're out there talking with folks, for sure. But that's great that they were open-minded. And by the way, the med staff has been spectacular with this, and Shanna and your team has been spectacular. We get a lot of very positive comments coming in from just the operation in general, but the communication across the organization is very strong, and the clinical support's very strong, and the nurse buy-in has been very strong compared to a lot of other organizations that we've been involved with over the years. A lot of our partners function similarly, but we've been in scenarios where it maybe hasn't been quite as easy. So you guys are doing a great job on that front. So Shanna, that kind of brings us to you for a couple of questions here. How did you from a nursing perspective, one of the things I say this time and time again, and people get, Shanna, you're talking nursing stuff again this here. But at the end of the day, nurses are really the linchpins in these acute care programs, and the support and the support of the nurse is critical, and having nurse buy-in is critical. And for us, it's a priority for these types of programs. Can you kind of describe, based on your perception from what you were hearing from the nursing staff, how did you feel about the process of moving this program forward, and then the subsequent launch process and the continued and ongoing communication with the nursing staff?
Yeah, thanks, Shane. When we started working with Teledyne, I think the biggest thing that we did to launch the program was to engage with them quickly on consistency and communication. And that even goes back to the provider piece. I think while we were engaging with the providers I think bringing the information and having consistent messaging that this is going to be a different type of a telehealth system, that there's going to be the opportunity for comprehensive coverage for your patients. Having them understand the differences of the current program versus what the new program was going to look like, even in terms of the fact that in our current program, the teams had to fax the entire EHR over for every new consult. And that the Teledyne group would be in our EHR, being able to see the same information on a patient that we could see, being able to have that consistent message and to keep telling that story over and over again as we were getting closer and closer to our launch date, helped with getting that, buy-in from our providers and from our nursing staff. As Dave mentioned, the former program was kind of more set up as an acute care situation for acute overnight hospital, acute overnight neurology concerns, and then like weekend coverage and holiday coverage. Whereas the new group, the new system with Teledyne was going to be more of like having a neurologist on our team. And so that difference and understanding that difference, I think, helped with a lot of buy-in. After we decided we were going forward with the group, we chose a implementation team at Jennie, and we worked closely with the Teledyne team with web calls. I made sure that we had a full implementation team of all the different specialties within our organization, to make sure that kind of all the T's were dotted and all the I's were crossed, and to make sure that they had all their questions answered while we were going through the setup process. Having leaders take that message back to their teams, again, I believe helped with getting our program launched. We also made sure to have a hospice provider on that team. They really didn't have a specific job, or they weren't doing anything towards the setup. But I think having them on the team and making sure they could hear what we were hearing, that they could understand how this was going to go. He helped facilitate, I think, often between his hospitalist group and other providers, as well as our teams, as we were getting ready to go through launch. And then Teledyne did a great job of doing a bunch of meet and greets with our provider groups, having them meet together with the different providers and to talk about any questions they had. As we were going into the training piece, Teledyne met with all of our nursing teams, and they made themselves available at all times. I guess they made sure that they were here at the morning shift, the afternoon shift, the night shift. They were even willing to come in. We have some weekender only groups, so they were willing to come in on a weekend. That was one thing from our nursing leadership that we heard over and over again, was how responsive Teledyne was to their staff and our staff's availability. Because as you know, if we can't get our staff over for training, that's going to be a big linchpin in getting this to be successfully implemented.
Yeah, for sure. That's excellent. And I think that's a nice nugget right there that Shanna mentioned in terms of having a sort of your own neuro launch team internal was a big factor, I think, as part of this. And especially in organizations such as yours that are your size, and really for all of them for that matter, but really to have that ongoing communication, that consistency is important. And these types of programs, again, when you're talking involvement from the stroke alert, so the patient may not even be at the hospital yet, all the way to discharge, and all the departments impacted along the way, and venues throughout the organization along the way are substantial. So kudos on putting that together. So it's, and again, I want to emphasize that process went so well, again, largely due to Jennie Ed's great team and communication. So the program's been in place for a while now. Could you maybe just provide an overview in terms of what are you hearing from the nurses now that sort of we've gone through the launch process? The program's been in place for many months, and what are you hearing from the nursing staff, whether it's the emergency department or the inpatient units or the ICU, or and then physicians in the emergency department and up into the floors in the hospitalist team, for example, the hospitalist that was taking part in the launch process. What are you hearing from those folks?
So yeah, they all feel that the whole program has gone very successfully. They genuinely feel that our response times have been improved greatly. Again, as we mentioned, the other group was not necessarily a set up to be an acute care, was more of an acute care type of a group where they responded to an emergency, but not necessarily brought that comprehensive coverage. One of the things that immediately blew away our team was the ability to have rounds with our teleneurologist, and the responsiveness of that was fantastic. The response from our team was, first of all, shock and amazement that we could have that continuity of care, that the provider basically arrived prepared for rounds and kind of knew about the patient beforehand, and then interacted with the patients much like they would if they were physically here as a provider here. And that quickly garnished trust from our hospitalist team and from our nursing staff. And I think really helped us gain immediate acceptance of the program. One statistic that's kind of interesting to note, Dave mentioned that possibly some of our hospitalists, some of our providers, because we didn't have this type of comprehensive neurology coverage here, were possibly turning away some of our patients and sending them off to other locations. In 22, we transferred 30 patients out, and in 23, we saw a decrease to 20 patients. So that was like a 33% decrease. Now, I genuinely believe that those 20 patients that they transferred out in 23 were probably needed to go type patients. They were patients we possibly could not manage here, and there's some things we can't do, but there's a lot that we can do. And I genuinely believe in 22, we were probably transferring a lot of patients out because of maybe the provider's uneasiness with being able to manage a neurology symptoms with the current group that we had set up.
Sometimes just having that neurologist in your back pocket really increases the comfort level.
Yeah. And prior, every time we consulted with the neurologist, it was a consult. It was a new consult every time, even though that patient might have been here for already 3 days and had seen a neurologist for 3 days. It was a new consult every time. So that meant For us, it meant a new provider every time, new orders. We had to fax the whole EHR over to that new provider. The response to that was very slow. Sometimes we waited hours to get a response from that provider. Whereas which is interesting because we actually have a decrease in our number of consults, total consults. So in 22, we consulted over 500 times with our teleneurology program. In 23, it was only 183 times. But yet we are treating more neurology conditions here, as we were evidenced by the fact we didn't transfer as many out. So what that tells us is the program that was set up is working, because every time we needed to contact neurology, it wasn't a new consult. It was bringing them into what's going on with the patient today and a continuation or that continuity of care that we've seen before. And then we were striving to achieve at Jennie, each prior touch point would require a lot of work by our providers on our end, both our MD providers and our nursing providers. And I think they were not wanting to do all that work all the time. Every single time it was, again, I think I said the word linchpin. It was difficult for them to consult with our prior group. So moving forward, the new group, having them be able to have immediate access into the EHR, having them, I think your group does some sort of handoffs of patients, which makes a huge difference. The doctors are familiar with the patients when they get on. All of that has led to a lot of success of the program. Oh, I do have another win that I want to share with you, if you don't mind. It's actually kind of a funny story.
We're all about the wins.
More wins, keep them coming.
This is a fun one. It's kind of what I was talking about their predictability of their response and their rounding. So there's a funny story about an RN right after we got started was rounding with the teleprompter, the telemonitor. And it's funny, she just takes the telemonitor from patient to patient that they're seeing, that the telehospitalists are seeing. And so she had the telemonitor with her, and she got stopped in the hallway and engaged in a conversation with another one of our healthcare people. And it was on a kind of more on a personal level and of a conversation. And the teleneurologist that was online jumped into the conversation, and it shocked them. But it again got talked to. It was a funny thing. They all laughed about it because he answered or something like that. And it was like he was standing there in person. But it's a fun story that we love to share about, how we've got our little robotic teleneurologist on our teleprompter. So.
Yeah, it's amazing how those conversations come about. In fact, we hear that quite a bit when the devices are being pushed down the hall, or if it's a wall mounted unit or whatever it happens to be. But it's pretty frequent, especially if they're mobile, rolling down the hall and they encounter someone in the hall and they start up a conversation with them and hey, I'm here. I can hear you. I can see you. So it really does lend itself to and at the end of the day, it's really how they build relationships by getting to know your staff. And I think, part of the challenges we talk about, the success of the program so far and the attributes of that success is sort of the small niche group that's part of the process. You mentioned things like continuity of care and responsiveness, and starting to have conversations with folks that are in the hallway. It's pretty difficult to, if you've been in the facility one time and to just start conversations in the hallway as you're rolling down the hallways is generally difficult. Would be for me anyway. I don't. Andy, you could probably fire up a conversation no matter what. But at any rate, it's really those relationships that start to carry the day. And you kind of hit the nail on the head earlier, Shannon, too, and you mentioned they sort of feel like they're part of your med staff. And at the end of the day, that's the goal. That's what you're trying to achieve really in any of these types of programs, is to intervene, or not intervene, that's the wrong word, but to accommodate and meet the med staff where they are and become a part of the med staff, become part of the fabric of that med staff. And ultimately that's where the trust starts to get built. And that's where you can really build powerful programs is by accommodating those types of interactions and encounters. And we see that often as well from the patients and the patients' families, where we've had a lot of and I can't speak if that's happening exactly on your end, but maybe it has, where the providers oftentimes will have conversations with the patient's families and and comment on
giving them
that.
updates and keeping them posted on how the patient's doing, things like that.
Yeah,
So
we're in the heart of the heartland here, and so I will say that the electronic version of healthcare still has not quite caught on with some of our older generations. As Dave mentioned, we have a strong relationship with a lot of our critical access partners, and with them come people who have been in the rural community, and they still would like to see a face-to-face person, to be honest, but they are very happy with the interactions because they do a great job of trying to make it as personalized as possible, for sure.
Yeah, absolutely. And I don't think you're hard pressed to find someone that would agree that the ideal situation is rock star physicians face to face and in person. I think everybody would agree with that. Me included. It's the reality is it's such a difficult proposition to deliver that level of service today, unfortunately. But that being said, having the physicians that can really develop those relationships is paramount. But beyond, that's where the nurse is so key in these situations. And really, they're not only the linchpin in the clinical equation, but they're also part of the driver in sort of developing that tangible aspect of a virtual encounter and that examination that really does prompt the nurse's hands involved with the patient care, where they kind of become those extended hands of the provider. And they elicit that real-time feedback, which is so critical, even if it's something as simple as listening with the stethoscope. And I don't know how many neurologists are still running around with the stethoscope around their head.
Not many from what we've seen. We talked about it once, and they're like, I can't remember the last time I used a stethoscope.
Yeah, well, but at any rate, the nurse being there and just being part of that examination and getting that real-time feedback for the patients is so key. And then, of course, once the patient starts to understand, they can avoid being transferred somewhere else and can stay home and stay in their facility or closer to home. It's a huge win for the patients, for sure. So let's talk a little bit about the success. You've hit on a couple of these items already in terms of what you think has led to the success of the program thus far, and in terms of how your confidence continues to improve and actually escalate since the program's been in place. Can you kind of maybe touch on or maybe go a little bit further in detail on some of the things that you think has contributed to the success of the program?
Well, first of all, I just kind of want to talk about the fact that we are an advanced primary stroke center. And so we just had our reaccreditation survey for that. So the good news is we are seeing improvement in areas of our VTE prophylaxis and anticoagulation for AFib, and our inpatient stroke alert for time to needle time, our inpatient stroke alert time to needle time has drastically improved since 2022. And we definitely are attributing that to the fact that our hospital's providers have engaged with the Teledyne providers and are working through our improvements that way. And without that collaboration, I don't know that those numbers could have improved so much. Teledyne definitely delivered on their promises of being a more comprehensive neurology program. And once that happened, our staff and providers really engaged with the group, and seeing that plan come to fruition. I feel like that was a game changer for us. Teledyne has been very responsive with any concerns or problems. Anytime you launch a new program, I don't care how much you prepare, you're always going to have glitches along the way. We've had a couple that have been minor, and Teledyne, your group has been very quick to alleviate any problems or concerns, which again continues to drive those successes. The on-site training, I think, again, I can't speak enough to that, to preparing us and leading down to our levels of success. I think the ability to not interrupt our staff's work, but for them to come to us and to be able to train our staff has definitely led us to the success. But for us, the biggie for us for the success, and again, this is just a few months in, I'm sure we're going to have more data as we get past the 1 year mark and get on down the road a little bit more was our recertification in our inpatient stroke, and seeing some of our inpatient stroke data come back a lot more positive than it had been historically.
That's a lot of fun to see those numbers actually improve, right? It's just it's a good feeling that because and whether it's stroke neuro or other programs, a pretty common question is, well, gosh, can this really can we really do this in a high quality way with this level of response? And it's we've seen it time and time again where the numbers can really improve drastically. And at the end of the day, too, in the larger centers, we do coverage in several large institutions where they had previous boots on the ground coverage. And boy, if you get into some of these large facilities, even if you have boots on the ground coverage, if they're tied up in a patient room on the 7th floor or in a different building on campus, for them to hightail it over to the ED or to the inpatient unit, sometimes it's you can only run so fast and or stop a procedure so in a certain way, versus being able to beam in within a couple of seconds is a significant advantage there. Well, that's great. In terms of the success, again, I want to emphasize too, Shanna, that at least from our perspective on our end, that the success of this program is this is a bidirectional thing. Any of these programs are bidirectional. You
Absolutely.
have to have
Yeah.
this is a partnership, right, between the virtual strategy and the remote site, and you have to have all the players engaged on the same page, working together to achieve these types of outcomes, because it only takes one weak link in that chain, and the program kind of gets a little shaky. So again, hats off, Shannon, to the phenomenal job you're doing over there in Jennie Ed. Well, let's pivot just a little bit over to, we've talked a little bit about the successes in the program and the fundamental changes, and then the launch process and the success that overall that you've had with the program thus far. Let's talk a little bit about community perception. And Dave, maybe we'll swing back your direction on this front and just discuss from your perspective what you're hearing from the community and what types of strategies have you deployed in terms of engaging the community on this front.
Yeah, great question. I think we would all agree that community perception is important. We at Jennie Edmundson, we want to be seen as a state-of-the-art facility in terms of our equipment, in terms of our technology. It's important to us. We've always been blessed to have a high level of loyalty from our community toward Jennie Edmundson, and that is important to us, and we take that seriously. And so we have been very pleased with the amount of positive feedback that we've received from patients, from family members that may have been present around the Teledyne teleneurology service. As Shanna has talked about, I would echo, I think it's gone really well. I think the process overall has been smooth. Now, that being said, obviously a ton of work has gone into it, and I think Shanna and her team have done a great job. I think the Teledyne team have done a great job. And I think not only the medical staff, but I think the community recognizes that. I think it's been very efficient. It's gone smoothly. And they certainly appreciate the service. And to kind of elaborate related to the loyalty to Jennie Edmundson, folks in Council Bluffs, they want to stay local. They don't want to go to Omaha or to other providers. They want to receive the service here at Jennie Edmundson, and having this partnership with Teledyne from a neurology and stroke perspective allows that to occur. And I think certainly patients and families appreciate that.
Yeah, that's excellent. And I know, I happen to have some family that lives over at least fairly close to the Council Bluffs area, and their perception of Jennie Edmundson's always been very positive and definitely on cutting edge on several fronts. So that's excellent. So if we ponder this, Dave, from a little bit different perspective, in terms of if you were a CEO in a different institution, if you're sitting down across from one of your colleagues and they're CEO in a hospital, whether it's a smaller rural hospital or a larger facility, and they were faced with a similar situation, or perhaps dealing with some of the challenges that you were hearing about along the way as your journey unfolded, what are some things that you might offer in terms of advice around this front on how these types of programs can potentially make a difference in their community, and any thoughts on recommendations, or maybe how to approach that, or just your general thoughts?
Yeah, obviously as a hospital CEO, your first choice, I guess, would be to have on-site coverage, as we've talked about today. That would be my preference as well, but obviously sometimes that's just not possible. And so in those situations, you want to find the best solution, the best process that works well for your facility, your patients, and your community. And as we've gone through this journey, as Shanna talked about pretty extensively, we really wanted someone to truly partner with, to work closely with, and really wanted a service that was comprehensive, and that as much as possible was set up to just like the provider would be on site, recognizing they're not, but to be set up as seamless as possible, to be as close as possible to having an on-site neurologist. And I do believe that our partnership with Teledyne and your commitment to getting this process set up as efficient as possible, as smooth as possible, has allowed us to do that. And as we've talked about, we've received a lot of positive feedback in a pretty short period of time. Honestly, we've seen positive results. Shanna shared some of the stats and improvements that we've recognized. That's really only been over the course of a few months, and I think that will only continue to get better. And so I think our recommendation would be, don't just look for a vendor, look for a partner, look for someone who is just committed to providing a high level of service to your patients as you are, and to making you as successful as you can be. And I think from our perspective, the Teledyne team has been very easy to work with. Shanna talked about that as well. Anytime issues have come up, they've been addressed very quickly. And we just appreciate the partnership and look forward to continuing to move forward.
That's excellent, Dave. Really appreciate that. I know that the comment, I jotted this one down, Dave. So don't just look for a vendor, look for a partner. And I can't emphasize enough how I've said that time and time. It's almost like an excerpt from one of the presentations I did here a couple of years ago.
Be.
But well, I doubt that. But I tell you, it's we definitely try to get to the point where it's considered a partnership. We don't ever want to be viewed as just a vendor, because it's, at the end of the day, these services are too, in my opinion, they're too difficult to pull together and provide high quality patient care when you take the position of a vendor as opposed to a partner, and to work together to work out, as you mentioned, there's always going to be some hurdles and some challenges along the way when you bring these programs in, and it's important to be able to have that relationship to work through those and get them ironed out so that you can have the best outcomes possible for your patients, as evidenced by, reduction in your door to needles, or patient, or I should say, notification of needle time on the inpatient side of the equation. Mm-hmm. So those are all fantastic stats and numbers. Well, I tell you what, I know we're coming up on time here. I can't thank you, Dave, enough for all of your help and support and willingness to spend some time with us, and Shanna, the amazing work that you're doing within Jennie Edmundson, and your willingness to spend time with us today on our podcast. I just can't thank you enough. Anything else you'd like to add before we kind of turn you loose?
I don't think, from my perspective, I would just echo how I started today, in that both Shanna and I appreciated the opportunity to have the conversation, share some of our story and some of our journey, and how we've embraced the partnership with Teledyne to really improve patient care and continue to provide the highest level of patient care that we can. So we appreciate it.
Well, that's excellent. Really appreciate your time again. And Shanna, again, thank you very much. And I want to emphasize too, I did leave out a part in terms of the success of these programs. Dr. Wanahita and her team they're amazing. And it's all, the physician leadership is incredible as part of this strategy. And we certainly couldn't do it without the physician leaders, a part of our entire organization. So the providers they're just so amazing in their willingness to really help out all of our partner hospitals. So shout out to them as well.
For sure,
Andy,
on that note too, Dr. Wanahita and her team would come to our physician leader groups. And I think I mentioned they did that meet and greet. That's the meet and greet that I was referring to. I'm sorry I didn't call that out specifically, but it was literally with Dr. Wanahita and our physicians, and they had a chance to talk with Dr. Wanahita. That's the meet and greet that I was referring to.
Yeah.
Yep.
Yeah. It's so helpful across all of our services to have the provider, sort of the lead physician, as part of that service line, to be able to chat with your local medical staff preemptively, to sort of just give them an opportunity to ask questions. And then there's ongoing support, right? We run into a lot of situations when you're in, whether it's a med staff meeting we're participating in, or just a follow-up education meeting that we're doing for the local medical staff. But oftentimes, as you're having those conversations, you're like, oh gosh, I had this patient 2 weeks ago. Should have I called you on that? I mean, stroke's pretty straightforward, right?
Right.
I mean, you're going to get consults on those, but there's going to be patients from time to time where, should have I done this? Should have I done that?
Mm-hmm.
What would you have recommended in this situation? And it really just helps break down those barriers with the relationships with the docs, for sure. Or the associate providers.
Yeah, absolutely. And I think to kind of shout out to Rachel for that nurse training.
Mm-hmm.
She's a background with critical care nursing, and she's passionate about making sure the nurses get this, that they understand, and that it's easy for them to get the training.
I would agree with that. And it was demonstrated by her making herself available to our teams, for sure.
Yeah, she's phenomenal. Again, cannot thank you enough, Dave Burd and Shanna Stofer with Jennie Edmundson Hospital in Council Bluffs, Iowa. Thank you so much for being a part of the Teledyne Pulse. We would like to thank you for joining us today. Our promise to you, the listener, you will be inspired, or at a minimum find value in the information shared in this podcast. Please offer a comment or offer feedback so that we can improve this podcast and better meet your needs. Please remember to share this podcast with others that you feel may get value out of this by listening. And it's always helpful to subscribe to the podcast channel so that you're aware of future episodes and releases. In addition, if there is a rural health topic you would like to have covered on this podcast, please leave us a comment, or you can send an email to pulse@teledynehealth.com. That's pulse@TELEDIGMhealth.com. For more information or general inquiries, please visit teledynehealth.com.